Hello, this is Ileana Piña, and this is my blog. I'm here at the American College of Cardiology meeting where there is an electric buzz, and everyone can feel it, from the ability to be together again for the end of that terrible COVID era that we have lived through. Even though COVID's still around, it hasn't gone away, but some of the parameters have changed. And it's really good to be together, seeing all of my friends. I want to talk to you a little bit about that definition of heart failure. We've done this before in the blog. We have talked about what the definition of heart failure is. And remember that it's not just that ejection fraction, it's also things like NT-proBNP and signs of congestion. Congestion may be looked at in a chest x-ray, a CAT scan, a good physical exam that shows congestion to confirm the presence of heart failure. We've come a long way, and now we've defined the pieces, the slicing and the dicing of the ejection fraction. We used to say that 40 or less, well, maybe actually 35 or less, was the low or the reduced ejection fraction. That's how we started with the HFrEF. And then we were calling anything over 40 HFpEF or preserved. But we have learned a lot from the trials. The trials have actually informed us, as vice versa, that we should be informing the trials. It's been the other way around. And maybe true HFpEF doesn't really start until 50 or higher. And I think the best example of that is the Paragon trial, where the point estimates change when you get to those higher ejection fractions. So maybe the real HFrEF is anything below 50. And maybe it's mild HFrEF, but now we call it MREF. In the slicing and the dicing, we have come to, somewhere between 40 and 49 or 35 and 49 could be the mid-range. Our European colleagues started calling it that. And then there's that other group, the patients who have improved, the patients who had maybe pretty severe HFrEF, and because of the medical therapy, have gotten better. And their ejection fractions may have almost normalized, even though maybe they don't really truly normalize. But they're certainly not 20 or 25 anymore. Maybe they're 40, maybe they're 45. And we think that may be a different group. Again, another slicing and dicing. Those are called the improved, the IMPs, IMP. Why am I bringing all this out? Because when you're doing your clinic visit and you are writing down that physical examination and you finish your note with an assessment and a plan, call it what it is. Right now, Medicare doesn't recognize any of these other separations, all this dicing. They still call it systolic and diastolic, even though I hear that the ICD-12s may be coming out very differently. But put it in your note. I start my note saying, this is HFrEF, this is HFpEF, this is MREF. Why? Because it makes you think of what you need to do with that designation and the patient that's in front of you. Our goal is to get the right drugs to the right patient at the right time for the right reason. Isn't that our definition of quality? I think it is. Thank you for joining me today. This is Ileana Piña signing off.